Welcome to the 2021 Tufts Research and Data Symposium for Food and Nutrition. My name is Hager, and I'm a PhD candidate at the Friedman School. We're moderating this session titled Using Food as Medicine. Before we get started, I just want to let everyone know this session is being recorded. You'll note that you are muted to facilitate conversation among the panelists. If you have a question, please type it into the chat and we will moderate the Q&A at the end of the session. It also suggests selecting speaker view in the upper right-hand corner to highlight the presenters. The structure of this panel is about 30 minutes of introduction to the topic, followed by another 30 minutes of discussion and Q&A with the audience. So I'm absolutely thrilled to introduce our panel today, given the deep breadth of experience from all our presenters. So we will hear first from Carmen George and Kymie Thomas from Community Outreach and Patient Empowerment on their impactful produce prescription program operating in the Navajo Nation. COPE is a nonprofit out of Gallup, New Mexico that works in close partnership with Brigham and Women's Hospital and Partners in Health. Carmen has been the research and MEQ manager for COPE and Brigham and Women's for over 6 years. And Kymie is key in operating the Navajo fruit and vegetable prescription program in collaboration with healthcare professionals who serve the Navajo communities. We're very grateful that one of these key physician champions is also joining us today, Dr. Preyanka Makadia, a family medicine physician, a lieutenant commander in the United States Public Health Service Commission Corps, and director of the Fruit and Vegetable Prescription Program. We'll hear next from Dr. Chris Esguerra, Chief Medical Officer at DME Consulting Group. Chris has led systems transformation, program evolution, public and private partnerships, leading to outcomes meeting the quadruple aim of improving health, cost effectiveness, enhancing the patient experience, and supporting provider well-being. Chris will speak to how and when food as medicine services are currently supported by health insurance, in addition to complexities in the partnership between community-based organizations, health systems, and payers. And finally, we'll hear from Sarah Downer from the Center of Health Law and Policy Innovation at Harvard Law School, and she will discuss equity issues within existing food as medicine policies. At the Center for Health Law and Policy Innovation, Sarah directs a whole person care initiative, which seeks to improve care for underserved individuals at every point of interaction with the healthcare system. So before handing it over to the panel, let me just briefly set the stage for discussion. So food as medicine interventions are of rapidly growing interest to healthcare systems, payers, patients, and policymakers. Such programs can be defined as integrating payment for healthy food or direct provision of it to patients as part of a healthcare intervention in order to improve diet-related health outcomes. Most, but not all, target food insecure patients. Major examples include produce prescriptions, wherein patients typically receive a voucher or electronic debit card to access free or discounted produce at retail or farmers markets. And the other leading model is medically tailored meals, and these are fully prepared, often home-delivered meals created by a registered dietitian nutritionist based on a specific diagnosis. So why food is medicine? We know that suboptimal diet in the US exerts a tremendous health burden, with more than 300,000 annual deaths from cardiovascular disease and diabetes attributable to suboptimal diet. And tragically, these conditions disproportionately affect the most vulnerable in our society, including low-income households, racial and ethnic minorities, and the elderly, highlighting the wounds of systemic racism and disparities in the US economy, food systems, and healthcare. Fortunately, food as medicine provides an opportunity for improving quality of care for these individuals, but ultimately cannot address the root causes of these disparities on its own. So finally, before passing off, I'll just contextualize that emerging food as medicine research has shown, largely from pilot studies, clinically relevant health gains over relatively short periods, including even some reductions in healthcare utilization. But there's much to learn about these programs and a need for stronger study designs in the future, which is certainly ongoing across the country. So with that, I'm going to turn it over to our panelists, and Carmen and Kymie, I'll let you take it from here.
Hi, everyone. Welcome again. My name is Kymie Thomas, and I'm the program lead for the COPE program, specifically the Navajo Fruit and Vegetable Prescription Program. And I'm here with my colleague, Carmen George, and also the clinician that we work closely to implement FERX, Dr. Preyanka Makadia. So I'll go ahead and start off the presentation with just giving a brief overview of the work that COPE does, and specifically how the need for the fruit and vegetable prescription program was identified within the Navajo communities. Next slide. So COPE is a community and outreach patient empowerment program. Is an American Indian nonprofit community organization that has worked to reduce chronic health disparities on the Navajo Nation since 2009. There are currently 7 programs within the COPE organization who help us collectively address these issues, and we all work collectively to strengthen the health outcomes for Navajo people. Since 2014, we have engaged in programmatic and policy initiatives to increase access to healthy foods, beverages, and to incorporate a lot of traditional foods on the Navajo Nation, utilizing the concept of food as medicine, and then just that being the basis for overall health for the Navajo people. Next slide. So identifying the need within a community, once we identified the need that for the level of diet-related diseases within the program, we had to tailor a program that is primarily targeted for a specific regional area, being the Navajo Nation. With that, we had to identify the need based on community feedback, the resources that are within the community that we were able to utilize, and also sort of looking back and seeing like the health indicators that are within, the population that we are addressing, if there is, high rates of a certain disease, of diet-related diseases and things like that. And the initiative that we had implemented to address these disparities is, the fruit and vegetable prescription program. So the overall, goal of it is to improve health outcomes among Navajo people. So some of the questions that we looked into when identifying the need was, what resources are available within these communities, what can we strengthen from the bottom up to be able to provide these resources not only for participants, but also community members who, could also benefit from this program. And then also which population has the highest needs. So, with that being moms or children, primarily, those are our targets, but, just really looking back at health indicators and overall statistics for the regional area. And then, lastly, how do we tailor the program to become individualized across the large geographical area that meets, all of the needs of the community, whether, they're patients or they're going to, just buy food. So just looking at that, we sort of, the development of the FERX program came about. Next slide. So just to give you an idea of the scale of the Navajo Reservation, the Navajo Reservation spans across 3 states. You can't really see the lines among them, but it's divided up between Arizona, New Mexico, and Utah, and the reservation covers a large portion of Arizona and has a land base of approximately 27,000 square miles. There are fewer than 15 grocery stores on the Navajo Nation. Families often have to travel 2 or more hours to the nearest largest city to be able to obtain high quality produce or, actually a variety of produce. Families living on the reservation face food insecurity rates 5 times the national average. And our partners with the clinics and early childhood centers, we have 11 currently implemented. The yellow geotag markers actually indicate the number of stores, and also the number of clinics that we partner with are highlighted. The little circle is actually where the COPE program is located. We're located off the reservation. It's, a little town called Gallup. So that's primarily where a lot of our work is based out of. So we do serve all of the Navajo Reservation, which is, I guess described as a food desert. Go ahead, next slide. So by tackling those issues, the development of the Navajo FERX program came to be, and the overall mission is just the ability for us to overturn longstanding historical health inequalities, and then just aligning the work that we're doing to transform this change that we hope, will take place over time. So, improving health outcomes or the quality of life for our community members. And the goals of our FERX program are to increase access to healthy foods among Navajo families, to increase their consumption of fruits and vegetables, and also more importantly, to improve health outcomes by a group of people that are primarily affected by diet-related diseases at a higher rate. And then also just looking back and stimulating the economy to promote the local sales of foods on the Navajo Nation. So if there's gas stations down the road, just being able to provide the resources for the gas station to be able to acquire, healthy fruits and vegetables for our participants or, for community members themselves. Next slide. So our program specifically, we target 2 different populations, pediatric and maternal participants. We started the program in early 2014 at 6 clinical sites on the Navajo Reservation. Since then, the number of participants or the number of partners that we've implemented FERX with has doubled. The way it's set up is the families attend monthly education sessions for 6 or 9 months, depending on their cohort selection, so either pediatric or maternal. The vouchers are then distributed on a monthly basis after the participants receive a nutrition education component, and then those vouchers are able to be redeemed at our partnering stores. The maximum amount of vouchers that a family of 4 or more can receive is $112. So just looking back at it, we have provided them with the additional supplemental food vouchers to be able to help them, but also promoting health literacy and nutrition literacy for families, and then just determining from there how they're able to implement that into their current diets, as well as physical activity. Next slide. And my colleague Carmen George can highlight some of the data findings that we've found.
All right, thank you, Kymie. So just to kind of talk about when we started the program, I remember when we had to go out to the stores and ask them if they would be willing to accept fruit and vegetable prescription vouchers. So the first thing we did was we did kind of an assessment of all the stores on Navajo Nation and just kind of saw how many fruits and vegetables were in each store. So that's part of the data that we had collected to kind of see the readiness scale for each of the stores, and then working with the clinics, just kind of looking what stores were nearby the clinics that were ready to start accepting vouchers. So I think for me, I'm from the Navajo Nation, and just talking with the store owners and the store managers, I think was a learning process, because, I just found that a lot of the owners and managers really wanted to help the Navajo people, that they didn't like selling junk in their store, but that's what was selling. So I think that was one thing that when I walked away from meeting with the store owners, just kind of how to promote healthy food. And since then, we've been working with at least 26 stores to promote healthy food and beverages in each of the stores, whether it's helping them find funds for display cases as far as fruits and vegetables, helping them with their marketing, but just really learning, what it's like for store owners, I think has been really eye-opening. But also on the other side, just talking with the participants that had joined FERX, I think, we can talk about how there was increase of fruit and vegetable consumption, but I feel like to hear from the participant themselves, it's something that I wanted to highlight today. So a lot of the participants that joined FERX, they had a variety of health-related reasons that they joined, whether it was for their child or their grandchild or their own personal health. And so just having this available to them and these vouchers, giving them the opportunity to try healthy foods, I think is really neat to see. We had one success story of a grandmother that needed a surgery, but her A1C was really high. And so, but after this program, she was actually able to bring her A1C down and do the surgery. So there's a lot of success, not only with the participant themselves, but at the family level. So I think this program really gets at the food insecurities that are experienced by a lot of families. I think it's when we were collecting data, over 70% of our families are food insecure. And so when we had first started this program, we had the criteria was for the child to be obese or overweight. And we just learned that a lot of families don't like to identify their child that way, so they weren't joining the program. So the first year of the program, we only had maybe 10 participants. And since then, we've been using the food insecure criteria to have them participate. And now we have 300 families a year that participate at least. So I think just kind of meeting with the community, learning about the participant needs, the store needs. I think in that way, you really learn what is best for the health of the community and what participants are saying and how things can change. When we first started the program, I know a lot of store managers, they didn't know what fruit and vegetables participants would buy. So we would do surveys and we'd send them, these are the top requested fruits and vegetables, and that's how they would buy it. So I think data to inform and data to change programming, I think that's really helpful. So I just wanted to share a little bit of those findings and a little bit of those stories. And I think that's it.
Amazing. Thank you so much, Carmen and Kymie. With that, let's keep building off of this story, and I'm gonna hand it over to Preyanka, who can talk about what it's like to work with this program from the perspective of a physician.
Thank you, Kurt. So I'm going to describe a little bit more about what it's like actually on the ground implementing one of these programs. So the FERX program, as Kymie described, has two different cohorts. We have our maternal cohort and our pediatric cohort. For the purposes of this presentation, I'll focus primarily on the maternal cohort. So the first step is, how do we find patients that are eligible for this program? When we have patients that are establishing prenatal care, we actually screen all of our patients for food insecurity. And the tool that we use is, it's only 2 questions, and it's the 2-item hunger vital signs screening tool. And even though it's a short questionnaire, it actually has between 89 to 97% sensitivity and between 80 and 84% specificity, which among the food insecurity screening tools out there is actually quite good. And so this questionnaire is built into the electronic health record and administered by nursing staff, usually during the first visit. And the 2 questions that we ask are, in the last 12 months, did you ever worry whether your food would run out before you got money to buy more? And then in the last 12 months, the food that you bought didn't last, or you didn't have enough money to get more. And the answer choices are often true, sometimes true, or never true. If a patient answers often or sometimes true to both of the questions, then the likelihood for them to be food insecure is quite high. At that point, they're referred to a nutritionist that's actually embedded into our women's health clinic, which will, and then they will perform an intake and they ask several more questions. So things like, what are their current eating habits like? What are their shopping patterns like? And getting a sense of how they might benefit from the FERX program. At that point, they're formally enrolled and they are eligible for the duration of their pregnancy and 12 months afterwards. So that's sort of the time frame over the last cycle that we've been working with. And with each, every month they get these vouchers, and I can actually show you, I don't know how well you can see on my camera, but each voucher is worth $7, and they can use it at about 35 different grocery stores and smaller shops on the Navajo Reservation, and they're all kind of listed on the back of the booklet. And every maternal participant gets one of these booklets, and then she can get an additional 4 per member of her household. So as Kymie had mentioned earlier, that comes out to about $112 per month. With COVID, we have thankfully been able to continue our program and sort of found creative ways to counsel patients over the phone and either mail them their vouchers or have them come pick it up, just social distancing protocols at the hospital. And there are some like foods that are considered acceptable and not acceptable. So the foods that we encourage participants to purchase are fresh and frozen fruits and vegetables without additives, as well as native foods. So corn, blue corn mush, sumac berries are foods that are okay to purchase. We try to discourage things like canned fruits with like preservatives or syrups, and actually have a list of not acceptable foods, but we give this to our participants as well, kind of highlights acceptable foods and not acceptable foods, and sort of use this as a guide for patients. And then every month they check in with our nutritionist to just see how things are going, review what types of foods they've purchased, and give them some more meal planning tips and ways to sort of optimize their diet. Many of our participants, unfortunately, do have gestational diabetes and other health conditions like gestational hypertension or chronic hypertension that we are working to manage. And by prescribing this type of diet, we're able to offer a solution, not just tell people, hey, do one thing, and not really give them a way to actually implement those changes. And then after the period of enrollment that they're in, we perform an exit interview and just get a sense of what their patterns have been and how they've changed. And we've had quite a few success stories. Really, one of the things that is super encouraging to see is how much lifestyle change has kind of come from this. People have truly changed how they eat and how their families eat. And not only that, but their kids are asking for nutritious foods, where in the past, their snacks, they would ask for chips or candy and, just more junk food. But now we're asking for celery and apples and more fruits and vegetables. So that's really encouraging to see. And moms have sort of shared with us that, in pregnancies that they've not participated in FVRX compared to pregnancies that they have participated in FVRX, they do see a difference with their kids, whereas their older kids might, choose more filler foods and snack foods like potato chips. Their younger kids kind of want to eat more healthier foods. So it's been really rewarding to be part of this program and see it on the ground. We are looking to expand. So we're planning to expand this program to our diabetic population. And I'm really excited for that and what hopefully impacting health outcomes over the next year.
Excellent. Thank you so much, Preyanka. So we are going to shift gears and hear from Chris, who's going to talk a bit more on the policy sides and give some insights into how these programs might be able to scale in the future and or some of the barriers that might be preventing them. So I'm going to hand it over to Chris to give us, he can help us better understand how these might play out on a national level.
All right, thanks, Kurt. So hi, everybody, and thank you for having me. So what I'm going to talk about are essentially some of the megatrends in healthcare and how it's starting to incorporate more and more addressing social needs. You're probably all familiar with the buzzword of social determinants of health, and understanding that this is a big giant workaround in the US. Sarah, who will follow me, will explain all of that and to why I'm calling it a big giant workaround. However, from the healthcare perspective, several things have been happening nationally and in many states, actually. So several examples are going to be with Medicare, the opening up of the supplemental benefit structure that then allows, and actually where the federal government and CMS encourages Medicare Advantage health plans to put in their supplemental benefits things that will address the needs of that population of seniors 65 and over. And as a result, we have started to see more Medicare Advantage health plans cover medically tailored meals as part of a benefit, defined specifically, but that's part of it. In Medicaid, which it's state by state, we're seeing more and more an incorporation of and addressing social needs, and in particular, food insecurity, whether it's specifically calling out medically tailored meals as something called in lieu of service. That is, it's something that is preventing a higher cost healthcare utilization, so a hospitalization in the setting of congestive heart failure, for example, or full-on nutrition insecurity interventions in the case of North Carolina and its Medicaid transformation. Now, from a policy perspective in integrating these things into healthcare, that's all well and good. And there's also further push, and actually in 2019, the National Academies of Sciences, Engineering, and Medicine did put out a report called Integrating Social Care into the Delivery of Healthcare. You can see that here. And the whole idea is what's the national policy framework? Who is the workforce to be able to do this? What are the financial components? How do we even begin to implement this? And I'll start with saying that this is challenging. By acknowledging then that we need to incorporate and address social needs and the delivery of social care into healthcare delivery, we're now creating an interesting asymmetry or power imbalance, largely with community organizations now having to interact with healthcare organizations. So in this particular setting that I'm talking about is health systems and health insurance. And the stark reality is that a lot of community-based organizations are not ready to do that. They're the basics of having just a discussion of partnership and the power dynamics therein. Health plans are very good at being sort of the big gorilla in the room and kind of dominating everything. So we have a power dynamic issue there. We have the education issue of having community-based organizations have the health plans or health systems understand what they're truly offering. There's a component of just even being able to contract. So a quick example, there was, and this was when I was working with a large insurance plan that covered both Medicare, Medicaid, and dually eligible folks for Medicaid and Medicare, vulnerable population. And we were actually trying to get a local food organization to contract with us to serve our population in San Diego County in Southern California. And so just to map out capacity needs, from a health plan perspective, it was easy for us to identify potentially 2,000 individuals that we could easily refer to this program for medically tailored meals. This food organization, their capacity on an annual basis at that time was around 300 individuals. And I was ready to more than 10, close to 10 times increasing their volume. And of course, for them, that was very overwhelming. And so we needed to talk through what would that capacity building look like. Then there was just even the contracting process and IT security, HIPAA, and being able to share information and them getting an NPI, National Provider Identification Number. All of these things that from the perspective of the health system and healthcare in general these are just the things you do, but for a community organization that has never participated in healthcare delivery, these are new. And in particular, the IT security components, privacy and all of those, that was a challenge, and gladly we had some champions internally from our IT team helping the organization get through that, or else we would have just busted their IT budget for at least 2 years of their budget cycle. And so this area of capacity building becomes really important, and that's part of what makes it challenging to do. The interesting other challenge actually on implementation was how are we going to pay them? I mean, my running joke at the time was, I want to give you my money. But we couldn't figure out how best to do it. And we had to start with, which is for health plans, suboptimal, an invoice method. And we really wanted to move them more to a claiming method where for a health plan that actually allows us to tag it as a healthcare expense. Whereas with invoicing, then there's some interesting technicalities there, but it matters in terms of how we tag it because of how we want to count it when we're actually reporting to, say, the state and any other regulatory agencies. And so these are just a small set of examples of how challenging it can be. Now, that's not to say this is impossible. There are playbooks being written, developed, organizations like the California Food as Medicine Coalition, the National Food as Medicine Coalition, that are working on this to be able to really help community-based organizations interact with health systems and health plans in order to do this. Many states are already gearing up for this. California is well on its way. North Carolina is very much at the throes of putting this all together. And not surprisingly, we'll stumble. I think the key, though, is to make sure everybody is being at the same table, having those discussions, and also addressing the power dynamics and being able to understand where each are coming from. And then there's a role of capacity building and identifying who will fund that, how will we fund that. And so with that, I'll take it back to Kurt.
Excellent, thank you, Chris. Yeah, and having worked previously at a nonprofit organization, I've 100% seen the issue you've identified as well, as this mismatch between wanting to serve as many people as possible, being limited by scale, but also like a genuine desire from both the healthcare partner and community-based organization to partner together. So thanks for bringing up these kind of real life challenges that happen when we try to implement these programs. So with that, I'm going to pass it off to Sarah, who will wrap up kind of this initial panel presentations, and then we will open up to discussion and questions.
Awesome, thank you, everybody. Can everybody see the slides? Yes? Help me out, Kurt.
Yes, looks good.
Okay, fantastic, perfect. Hello, everybody. My name is Sarah Downer. I'm the Associate Director of our Whole Person Care portfolio of work at the Center for Health Law and Policy Innovation at Harvard Law School. We have a food as medicine project there where we really focus on the integration of food and nutrition interventions into healthcare specifically. So into the delivery, into financing. And the goal is really to improve healthcare for people who are underserved and living with or at risk for chronic disease. So that's the context and lens in which we do our food as medicine work. And over the last decade, right, we've really accelerated the integration into of food and nutrition interventions into our healthcare systems. We've seen advocates really pushing for this, and we've had some success. So we are building through the hard work of advocates like everyone on this call, the on the ground innovation and programming of the folks on this call and across the country. We are building food and nutrition interventions into our healthcare system, but we're not doing it comfortably, I would say, and we're not doing it equitably. So Chris spoke a lot about the challenges there. I think you've heard a lot about, how we need to really focus on building these programs and listening to participants and the needs of participants as part of that. So when we are looking at this at the center, we really focus a lot on how this integration of food and nutrition works within our two largest public insurance programs of Medicare and Medicaid. And that's for a couple reasons. One, because the private insurance market can incorporate food and nutrition interventions whenever they want to. So if employers want to do this in their healthcare plans, if state insurance programs, state employee insurance programs want to do this, they can do this at any time. There aren't really the same regulatory barriers that exist in our Medicare and Medicaid programs. And changes to these programs really influence the private insurance market anyway, right? And then finally, there's a really high number of individuals who are living with chronic diseases in these programs. So any changes here are really going to have a big impact. And just to pick up where Chris left off, right? So what we're looking at here is the progress that we've made in our Medicare and Medicaid program. We're creating some room and some opportunities in these two programs through advocacy, but they do not reach everyone. So here we have Medicare, right? And Chris talked a little bit about the opportunities within Medicare. All of those, though, exist within the Medicare Advantage program. So we've got Medicare, the program for mostly seniors. We've got 63 million people enrolled across the country. So 60% of those recipients don't have any access at all to food and nutrition interventions through Medicare because they don't get their Medicare through what's called Medicare Advantage. Only about 40% of Medicare recipients are getting their insurance through Medicare Advantage. And so only those individuals would have access to some of these windows of opportunity that we've created through our advocacy, right? And so what we're seeing also is that that's not equitably distributed across the country. So you've got geographies where there's a lot of folks who are participating in Medicare through the Medicare Advantage program, and they have access to these services. And then other states, so you see that where there's these orange states on the slide, where there really is not very much coverage of Medicare folks through Medicare Advantage, and they have no opportunity to get access to these services through Medicare. Then you have Medicaid, of course. So you've got 75 million people in the country covered through Medicaid. But what we're seeing again, it's very state-specific. Medicare is a very state-specific, or Medicaid is a state-specific program. If you see one Medicaid program, you see one Medicaid program. And so you may have opportunities to cover food within Medicaid within a certain state using flexibilities, right, that they really work to make real. But you're not going to see that in every state. And so basically what we have here, right, is we have this, if you sort of look at healthcare, traditional healthcare system as a house. Let's think of it as a house. And we have not really invited food and nutrition interventions into this house before. We haven't really invited social determinant of health interventions, health-related social need interventions like housing and other things into this house before, right? And if you were going to do that, you know, any good lawyer would tell you if you were going to invite folks into your house, you would take a look around at the sidewalk leading into the house. You might move your kids' shoes or anything that was in the path, right? You would maybe take out a thorny bush that was like hanging over your porch, things that folks would run into as they came in the door. You'd also think about what do your steps look like? You'd think about what people were going to do when they came into your house. How are they going to get along with everyone else who was in your house? Where were you going to receive them? What rooms were they going to be allowed to go into? How are you going to sort of rearrange the furniture so that they would be comfortable? Maybe they need a little bit of accommodation because they haven't been to your house before. So what are you going to do? So that's what you would do when you invite things in through the door. Here's how we're doing this in the healthcare system though, right? We're not inviting these interventions in through the door. The door is locked. And what is that lock doing? Where it's making all of the food and nutrition interventions that are available within our Medicare and Medicaid systems have to go in through the windows. This is very uncomfortable, right? They're getting in, you know, by clawing their way in through these windows and windows that we're opening through our policy and advocacy reforms. But what happens when they get in there is that they sort of stay cabined in the place where they come in. It's not very comfortable. This, you know, point of entry was not designed for them. So once they get inside, it's really difficult for them to work with the healthcare system as it currently exists, right? Because we haven't thought about how we're going to integrate all of this into the broader healthcare system. And why can't they come in the door? So this is what is actually keeping this door locked to our food and nutrition interventions and our health-related social need interventions more broadly. These are the reasons that are being given. So one is that there's a lack of research and evidence that shows that these interventions are going to have a particular health impact. Now we've started to see this research base being built over time, and it's extremely exciting. It's extremely compelling work, especially in the food and nutrition space. There are food and nutrition interventions that are being shown in the medical peer-reviewed literature to have impact on health and health outcomes, healthcare costs, healthcare utilization, right? All the things that we care about in the healthcare system. However, when we go to policymakers, they're telling us, well, we need more, right? So this is really important. We need to deepen the breadth of research in this area. And that is sort of a critical priority if we want this door to open. The second thing that we often hear is, well, this is not healthcare's job. This is social services. This is our social safety net. It's the job of our social safety net to deal with things like food insecurity, housing instability, et cetera. And so in the US, right, we actually spend most of our social services dollars, for lack of a better word, on healthcare. The balance between what we actually spend on our healthcare system and what we spend on our social services system looks completely different from what other countries do, right? Other comparable countries are spending tons more on their social safety net system and not so much on their healthcare system. So this is where the dollars are. And so we're going to have to deal with that. The fact that we do not make as much of an investment and as much of a spend in our social safety net, on our social safety net programs as we need to. And so it is logical that the healthcare system is going to have to pick up some of that slack. Another reason is confusion, right? So we just don't know what these things are. Chris said the word medically tailored meals. What does that even mean? What is a medically tailored meal, right? What is a produce prescription program, which is operating so successfully in Navajo Nation? We know because we've heard from these individuals, but they're not completely well defined. And there are groups that are working on those definitions. And really nice working definitions of those that are going to be probably written into what those look like when they're integrated into our programs. But by and large, clinicians are still confused about what these interventions actually do and what the impact that they're supposed to have, right? When do I give my patient a medically tailored meal as opposed to a produce prescription? When is that appropriate? So we need to do a lot of education and a lot of sort of getting together and working out what these interventions look like and then how they're going to be integrated into the system. And then the other thing is that there's this, but what about? So if we open this door to food and nutrition interventions and we invite them inside, what about housing interventions? What about employment interventions? What about, other things that we really think are important and really matter to people, right? We know food insecurity doesn't exist in a vacuum. It often exists with lots of other social challenges and social needs. So what about all those things? And so we need to keep the door closed because we can't invite everything in at once. So this is what's happening here. And the system that we're creating as a result is extremely inequitable, right? So you have disparities in access to these interventions, which are, have been shown to be very effective. And you've heard about that today. By insurance status. So if you're covered with a program that provides these services, good for you. If you're not, you're out of luck. By geography, right? So we're seeing lots of progress in California, lots of progress in New York, in places where there's a lot of sort of will to change your programs, your Medicaid programs to do these things, or there are insurers that are participating in the Medicare Advantage program that have a lot of risk tolerance and that are a little bit more sophisticated in trying to weed through what they're actually going to provide to their members. And then you also have, so now you have big disparities by geography, by population. And so we're really building a system over time that's just going to exacerbate the inequities that we currently see in the system, because we're not sort of stepping back and looking at the system as a whole and thinking about where it makes sense to start to integrate these services in. So that's what I'll sort of close with. And I think we're moving into Q&A. So I'm just going to share this Q&A slide that has all of our names on it. And we're very excited to take your questions.
Great. Thank you so much, Sarah, and for everyone on the panel for that overview. So I have a handful of questions for you all. I feel like I could talk with you for like another hour with the list of questions I have. But as Sarah said, if any of you have questions, please type them in the chat and we can try to incorporate them. So my first question I think will be directed just to finish off this conversation on inequities and what's covered. I might just first target this to Sarah and Chris, but anyone else, please jump in. Just to clarify the audience, kind of one of what are the solutions, big solutions to address some of these equity issues and how these programs are being covered currently in healthcare? It seems one, maybe the biggest one is just, we need federal legislation to make this a benefit in Medicare and Medicaid for everyone and not pursuing these piecemeal opportunities when they arise. Is that reasonable? If not, why? And what are other solutions that you two see?
Well, so I'll throw in my maybe controversial 2 cents. Legislation on the healthcare side should not be the primary place to actually be thinking about this. In fact, I think an overhaul of the Farm Bill should be the start. And we have evidence to show that the SNAP program has continually saved on the healthcare dollars on the Medicaid side every time there's a study on it. And that's not a policy for healthcare. That's a policy that's under the Farm Bill. And so again, it's a rethinking in the US and a reckoning of how do we spend on social services and social needs care overall. And then put incentives on the healthcare side to actually interact with the areas in and around social services so that there is more of that integration overall. Because then there are all these implications of how do we share data? How do we deal with separate funding streams and the wrong pockets problem and free rider issues? And there are good economic models around that, but I think the solution should not just be in healthcare, but through other parts of legislation.
Yeah, and I guess I would just add on to that and say that we can do legislation, right? It's a bit of a blunt instrument in the healthcare space, and it would probably make more sense for CMS and HHS to really sort of sit down and look at actually all the data that they're amassing on the ground. There's a lot of little experiments, right? So right now we're running basically the country as a healthcare lab where there's stuff going on in New York and California and North Carolina and Massachusetts. And then we are, and Medicare Advantage programs are doing lots of different things, having tons of different results. We haven't aggregated that data. Nobody's looking at it. Nobody's sort of accountable for what works and what doesn't. And we really need some actual commitment by folks who can really look deep into this and see what's going on and see what the impact actually is. So that's why, you know, we have an Aspen Food and Society project that I'm involved with at the Aspen Institute, which is looking deep into food as medicine research, what the gaps are, and drilling down there. But we want also to make sure that CMS needs to be more engaged in this work. So that's, I think, what we really want. We can do it through legislation, or we can do it through partnership with an agency.
Mm-hmm.
Great, thank you so much. Any other last thoughts from any panelists on this issue? Okay, so I'm going to move on. We do have a question from audience member, and I want to direct this to the COPE team first. And it's how important are culturally relevant and sensitive foods? How do they factor into your work? And can you speak a bit in terms of the receptivity of the stores and community members with the food being provided?
I can go ahead and answer this one. So looking back when this program was developed, you know, we'd always had the concept of, you know, going back and having the cultural relevancy as part of the program. And so that's where we incorporated the importance and of having the traditional food items available for purchase, but not only for what is provided at the store, but also partnering with local growers and local farmers who are able to produce foods that are traditional to Navajo people. And so just acquiring the foods in either through store purchase or through, you know, our partnerships with local farmers, you know, just incorporating that piece into it, and also, you know, educating families on, you know, the importance of cultural, like how to properly put these foods together, and how to providing them with different recipes that, you know, they're able to utilize when they're looking at incorporating more culturally relevant foods into the FERX program. And the providers have done a really good job with emphasizing, you know, the importance of also incorporating what worked or foods that we had previously eaten before, you know, and then just balancing that back out into the program now. But, you know, like the program is culturally tailored to meet the Navajo people and some of the our diets, you know, because they're a little bit different from other tribes. So just focusing on what's native to us, you know, has been a big part of the program. And I'm not sure if anybody else wants to add something.
Great, thank you so much. Yeah. think I'm just echoing that one speaking. So another question I had for the COPE team is this last year has been just so incredibly hard for everyone during the COVID-19 pandemic. And I can only imagine from your end too, just on operating a program like this with the disruptions of the last year and its scope between retail partners and families and healthcare. I can only imagine you all have maybe run into a lot of challenges in getting this program to still help as many people as possible. Can you speak to just how navigating this pandemic in particular with your work, how that's intersected, and what are some of the things you've been able to maybe adapt for and overcome to implement this program, both in the healthcare setting and kind of from your implementation side?
I can speak to like as far as like implement or the on my part about program delivery. We've had quite a few clinics across our reservation stop implementing FERX just because they don't have the capacity, because they were also assisting with other COVID related activities. And so we really left it up to the teams to determine if they are able to carry on the program, if they have, you know, the capacity and the power, I guess, to be able to continue to implement FERX. And fortunately, 7 of the 11 clinics that we partner with were actually able to continue. And with them, you know, we've had to modify the nutrition education components, so, you know, delivering like Dr. Makadia had said, you know, through telehealth or even through phone calls, or you know, exploring the possibility of moving our curriculum to an online setting so that it's more accessible and there's more engagement involved. But that's something that we are currently in the process of working towards, but really it's just a whole, you know, moving a lot of our program work so that it is able to function even in a virtual setting. I think for us has been a barrier, and also given that, you know, the limitations of technology on the reservation has made it almost impossible for some families to be able to participate, you know, in a Zoom setting or, you know, on a Microsoft Teams meeting. So just looking past, you know, things like that, where, you know, what is convenient for us, you know, isn't necessarily convenient for one team, you know, because the locations of each clinics are also unique. You know, some might have access to internet and others might not have any access. So it's really unique for all of our clinics because they have their own challenges. And then, you know, what like I said, what works for one team might not work for the other team. And so just really looking into how we can support these teams across with their different needs and variations of program implementation for them. But I'm sure Dr. Makadia can speak more on, you know, how they were able to deliver the program overall to participants.
Yeah, definitely. So there have been quite a few challenges that we've had to deal with over the course of the pandemic. So on Navajo Nation, we've had pretty much since March of last year, curfews as well as weekend lockdowns. So basically, like before, we have a local grocery store called City Market, similar to like a Kroger type of store, I think on the East Coast. So typically that grocery store prior to COVID would stay open till 10 p.m. With COVID, it's only open Monday through Friday until 7 p.m. And it's closed on weekends from all day Saturday, Sunday into Monday morning. So for families that are used to doing their grocery shopping on the weekend, it takes a lot of sort of prior planning and just organization to be able to get their groceries during the week if family members are working, et cetera. So that's definitely a barrier because many people can't do that. And then the other thing is that the vouchers that we typically give to the patients are distributed monthly, and usually they expire prior to, like, for the next month. So they're good for a month until they're supposed to get their next set of vouchers. One of the ways that we were able to overcome that is by extending the expiration dates. So patients were able to redeem the vouchers, you know, beyond that month timeframe that the vouchers are typically supposed to be used in. And those were definitely big challenges, but I think for people that were like really motivated, they were able to sort of work around that. As I mentioned earlier, we have one or two nutritionists that primarily help run the program, and they were doing a lot of check-ins by phone. And so we live in a very remote area, and cell service often isn't optimal. It's often hard to get a hold of people by phone. But we were able to kind of work through that and find times to connect and be able to sort of find creative ways to distribute the vouchers. That wasn't what we usually do, which is in person, sort of one-on-one counseling and voucher distribution. So certified mail, where people sort of sign and get the vouchers, having them pick it up from, a part of like the outside front desk of the hospital, and just sort of having it labeled and, ready to go for the patients, were ways that we kind of worked around some of these challenges. But we were able to keep it going, which I was really happy to see.
Good. Yeah. Well, great work to you all. I'm sure like now more than ever is when the community and patients you serve need this program most. And that must be such a hard challenge for some of those families with the limited hours already. And, what is a food desert to have those limited shopping hours, I'm sure has been a challenge. I can only imagine. Well,
may I mention one thing?
Yeah.
So I think one of the things that we need to keep our eye on as this sort of integration of food nutrition interventions into healthcare progresses is one of the issues with sort of having these interventions sneak in through the back door is that when something works, people are going to try to export that wholesale in a standardized way to other places. Whereas if we were considering sort of what a program would look like, more organically, we would be able to address some of the things like, okay, what foods should be able to be accessed in this intervention in these communities? What are the sort of the delivery mechanisms that make sense in these particular communities? And how can we build the flexibility into these programs from the jump so that we're not, fixing things when there's a pandemic, right? And all of a sudden we realize that there are rural areas where, access looks different. So I feel like we just need to think about that as we're integrating these things, and that is lost when we're not sort of all at the table talking about them and figuring out how they should work together.
Yeah, absolutely. And I wanted to add to that, Sarah, because Kymie, Preyanka, what you're bringing up is the need for that kind of flexibility. And frankly, the concern on a policy side, and I'll say state Medicaid agencies are notorious for this, will set out good things in intention, but define it in such a way that there's very little flexibility and you have to do it a certain way and doesn't necessarily acknowledge the communities and the diversity that is for that particular state. I'd say an interesting model, again, is North Carolina in that it acknowledged the need for that kind of flexibility and brought in the stakeholders that it needed to have that discussion as much as it could. And that's really where we have to be able to be thinking about this. And more so also thinking about what's the administrative burden that will be placed as these policies are developed. Yes, it's great to be able to implement that, but in the US system where we're still very much around fee-for-service, there's a hunger to tabulate everything, to get as much data about everything. That's a huge burden for everybody involved to just say, yes, I gave this meal to somebody at this time on this day. Do I need to know that? Probably not in that specific detail, but that's what our fee-for-service model in terms of payment actually forces a lot of us to do as a system. And so we need to be mindful of that. So there's flexibility in terms of policy, but also our payment models and in allowing the deployment of a lot of these really great programs.
All right. Thank you so much, Chris. I have more questions I would love to ask you all, but we are up at time. This hour has flown by. Thank you so much for all of our audience members, and enjoy the rest of the Tufts conference.